This is Tom Lüscher with Inside Cardiology, and today we're discussing guidelines, what it means and how do you interpret and use it. Now, first of all, here you see Moses from Michelangelo, and the question, what are guidelines? Well, guidelines guide. Guidelines are recommendations. Guidelines are not the 10 Commandments of Moses. The guidelines help to reach rational decisions, but it requires a doctor with clinical judgment as well. Okay, so what evidence do we have for guidelines? Well, we have registries, we have Mendelian randomization and randomized trials. Now, registries are real-world data. They're ideally prospective, ideally have a central lab, and ideally have external adjudication, but they provide associations, not causality. Mendelian randomization is an experiment of nature, and here, instead of a drug, we have a genetic mutation, usually a missense mutation that gets rid of a certain gene, and we compare those with a variant that's dysfunctional to the so-called wild type, and we get causality, but we need huge registries. And then we have the randomized trials, obviously classic randomization, double-blind, external committees that look at every single aspect of this trial. And this is, of course, the real basis. And if you want the 1A recommendation, you need 2 of these randomized trials to really support your clinical decisions. So let's say that, what is the difference between an association and causality? This is a classic example of an association. This is the density of the brooding stocks and the babies in Sweden. And it's highly correlated, and therefore the stocks bring the babies. Would you say so? Obviously, not even the children believed at these points. So clearly associations are not causality. So that's why we have randomized trial, and this is the William Harvey of evidence-based medicine, Austin Bradford Hill, who in the New England Journal clearly described what a randomized trial is, but his legacy comes from a specific trial comparing Magic Mountain treatment in the sun on a balcony with streptomycin that was discovered in the 40s and then used with eminence-based medicine until he wanted to really know what it means. And in the British Medical Journal, he says, the trial enrolled only 52 controls and 55 patients receiving streptomycin for 4 daily injections of 2 grams, and then of course they reported in 1948 in the British Medical Journal that 4 patients or 7% died with the streptomycin group and 14 or 27% in the control group. And this is the classic statement ever since. The difference between the 2 series is statistically significant. The probability of it occurring by chance is less than 1 in 100, so P001. That's evidence-based medicine as it started. But we started with registries in cardiovascular medicine, and the classic registry that created all the prevention we currently do is the Framingham study. And in Framingham, they just looked at around 5,000 inhabitants of a suburb of Boston, and they basically showed that age, smoking, cholesterol, blood pressure, and diabetes are related to outcomes, such as myocardial infarction, stroke, and premature death. There wasn't causality, but it was the basis for the trial, the 4S trial with a statin, the seminal trial, that then told us that really, and the same was true eventually also with blood pressure and diabetes, if we interfere with these risk factors, we can change outcome. So the weight of medical evidence is shown here. The randomized, controlled, multi-center, blinded trials, then sub-analysis of these trials, particularly if they are basically decided upon before the analysis of the database, and then of course real-world registries that can guide us as well. Let's look at Mendelian randomization. This is something a bit more novel, and it basically randomizes patients with a gene mutation and wild type. For instance, in this PCSK9 gene mutations that are associated with low LDL levels from birth, they showed in one classical New England paper that if you have the Smith-Sands mutation and low LDL levels from the very start, you have an 85% reduction in events. Amazing, almost an eradication. Can we achieve that? Well, within 10 years of the discovery of this gene mutation, we had drugs. And here you see the Fourier and the Odyssey trial, and both significantly reduced MACE. But you're a bit disappointed, and if you show it to your grandmother, she would say, well, it's not that convincing. Why doesn't it completely erase it, like in those with a genetic missense mutation? Well, why is the effect size lower in trials? Because the start of treatment is usually within 60 years of age, 50, 60, 70 rarely, with drugs versus from birth with a genetic missense mutation. And the short follow-up is also a big issue because it's 3 to 5 years in trials versus lifetime with a genetic missense mutation. So trials usually underestimate the long-term effects of such an intervention. So when we look at these trials, we have to ask, did they really ask the right question? Is it just a comparison of two drugs, or is it really a breakthrough? Is the design suitable? Are the right patients recruited, the ones I see in my clinical practice? Is it representative or a very, very selective group, as in some of the interventional trials? Is the effect size convincing? Did we reach the right conclusions? And so when we look at this, is it really representative? You can see the total patient population, then the screened patients, and the actual randomized patients. And here you can see that not always are these patients representative for the overall population that we see in everyday practice. For instance, in the Paragon trial, the HFpEF population are millions. Around 10,000 patients were screened, and eventually 4,822 patients, 46% of those screened, but a minute percentage of those in the real world have been randomized. That's a limitation that we have to consider whenever we read a particular trial. And this is even more interesting. In Sweden, they compared a randomized trial in patients with ACS with the Sweetheart registry, where they have complete representation of every single patient in Sweden, and you can see the mortality was double. So we have different patients. So are the patients in trials my patient? They are generally sicker. What we see in clinical practice, they're generally older, particularly in HFpEF and heart failure in general, and they're commonly at higher risk, and that we have to consider. And when we look at the effect size of a trial, we have to ask ourselves, are the number needed to treat good enough? And for what? Is it mortality? Or like in the colchicine trial recently, only revascularization or non-fatal myocardial infarction? For how long do we have these numbers needed to treat? Is it 5 years or is it a lifetime risk? Then the numbers needed to harm have to be very, very high, because we don't want bleeding in every single or every second or every third patient. And how severe is bleeding, which is important in cardiovascular medicine. And Rob Califf put it coined it really to the point, for a difference to be a difference, it has to make a difference, and that means clinical difference. So the golden rule is, for an ideal result, the numbers needed to treat should be below 50, numbers needed to harm as high as possible. Okay, so then the next problem is, what about trials with devices? If you ask a patient, do you want an intervention or a drug or placebo versus implantation of any device, this is much more difficult to randomize patients. Not many will say, yes, I go for that very design. And here's an example. In the Cabana trial, they recruited 2,204 patients, either to ablation of atrial fibrillation or medication, according to the decision of the treating physicians. And the intention to treat analysis showed an 8% versus 9.2% difference, a little bit less with atrial fibrillation of the overall MACE, and this was not significant. So can we decide based on that ablation doesn't work? Well, on an intention to treat, it doesn't. But one thing one has to see when we read these trials, in this very instance, 28% of the medical group eventually got an ablation, but they're analyzed as if they would have been only on medication. So this crossover in device trials is a real problem that whenever you read such a paper, look at this very aspect. Because when we do, as it appeared later on in Circulation, a on-treatment analysis, ablation versus drug therapy with atrial fibrillation on treatment, you can see that indeed ablation in red compared to blue in drug therapy did actually have an effect that was significant. So what can we say from that? Well, death, disabling stroke, serious bleeding, and cardiac arrest was 9% with catheter ablation, and in this analysis 12.3% with drug therapy, and this was a hazard ratio of 0.64 that was significant. Now, what is better in device trial, intention to treat or untreated analysis? I think we should really look at both to understand what's going on. The intention to treat analysis is unbiased, but it's diluted. The on-treatment analysis is biased, but it's real. So, although the New England Journal doesn't allow on-treatment analysis, we should always read this as well to reach a good decision. So how do we go from evidence to recommendation? In the philosophy of science, we distinguish between treatment of fact and statement of value. And that's not the same. This is not the same. We have the level of evidence and the recommendation class. And this is important. And what is the difference and what are the problems? The difference is that recommendations also depend on culture, on the healthcare system, on personal perceptions of interventions and the value and the actual events that we reduce. And therefore, in guidelines committees, how do they reach decisions then? Well, here they are. And this is the ESC Guidelines Program Committee. Different people, different background, they come from different countries, different healthcare system, different background, obviously, different opinions. And how do they reach the decision? Well, they are voting. And if 70% are for a 1A or a 1B or a 2A, then that's what's in the guidelines. So we have to be a bit careful with these things and remind us of Abu Eban, the late foreign minister of Israel, who said consensus means that lots of people say collectively what nobody believes individually. Guidelines are very important, and therefore have a look at my Manual of Cardiovascular Medicine. Every guideline is in there, and you should look at them, but look at them critically, look at the evidence, look at the trials and what they mean and whether the difference they show really makes a difference. Thank you for your attention.